And may I please request Dr. Shantanu Guho, Dr. Aniruddha De, Dr. B.P. Pandey, Dr. Bishokesh Mojumdar, and Dr. Sanjeev Mukherjee to join the next session as respected chairpersons and panelists. And for the next session, Dr. Ramakrishnan is our next speaker. It's a privilege of introducing Dr. Ramakrishnan to you all. Dr. Ramakrishnan is a professor of cardiology, AIMS. He has published more than 250 papers in index journals and being cited for more than 8,000 times, edited various books including cardiology clinical methods and chapters in international and national textbooks. He is the editor-in-chief for Annals of Pediatric Cardiology and on the editorial board of major journals. He is in the LIMCA books of records for single-day maximum number of BP recording anywhere in the world. He has also been the principal investigator for many projects and winner of many prestigious research awards. So it is time that we invite Dr. S. Ramakrishnan to present his talk. Thank you.
Thank you, Dr. Roy, for such a nice introduction. So, is my slides visible?
Yeah.
Yes, sir.
Yeah. So in next 20 minutes time, I will take you through the story of the ATTR amyloidosis. So as always happens, this remained possibly it remains quite a bit of an orphan disease in cardiology. Like so, most of the time we rarely find patients referred to AIMS with a proven diagnosis of amyloidosis or even suspected diagnosis of amyloidosis. So oftentimes they are all missed from periphery when they are referred to higher centers. They because the patient present to you with only heart failure. But like what happened in pulmonary artery hypertension, like with the availability of these drugs, the pickup rates of pulmonary artery hypertension improved. So nowadays it's very uncommon for us to first diagnose idiopathic pulmonary hypertension in our OPDs. Most of the time, the patients come with a label of pulmonary artery hypertension. Possibly, I envisage that same thing will happen with a renewed interest in various therapies that are becoming available for amyloidosis. But only problem is, as you come to know, the therapies are currently out of reach for most of the Indians. So what is this amyloidosis? So amyloid is like an amorphous fibrillar material. It's kind of an extracellular deposition of the pleated structure, that extra protein, either because of increased synthesis or because of reduced clearance. They destabilize the native protein and they kind of become a pleated structure and they get deposited in the various systemic and localized organs in the extracellular matrix. So this is the two major forms of amyloidosis that happens. Either they are like the AL amyloidosis, the various light chains they get from the plasma cell dyscrasia, they are released and they are more in production. Lesser amount can be cleared. They get misfolded light chain aggregates. They form with the profilaments. They form the amyloid fibril. They get deposited in various parts of the heart. The same thing happens with ATTR. The ATTR, the TTR protein. They form dimers and they get misfolded and they form the amyloid fibril and they get deposited. And they are generally disease of the elderly most of the time. So what are the various common types of amyloidosis before we delve on to ATTR amyloidosis per se? So the most common amyloidosis that you find is an AL amyloidosis. That is the light chain, Ig light chain deposition. So 80% is because of the lambda light chain deposition and 20% is because of the kappa lambda light chain deposition. That's a separate entity that I think we'll not be talking about it except for the how to diagnose. So ATTR amyloidosis is the transthyretin deposit that happens. These are two forms that are there. One is the variant forms and the other one is the wild type. So we'll be coming about this in later. So the variant form, you should remember that ATTR amyloidosis has, because that has important connotation when it comes to therapy. So variant forms as well as wild type. These are the two types of ATTR amyloidosis. There are various other proteins that can form amyloid fibrils, especially in the earlier era, we used to see a lot of this secondary amyloidosis following tuberculosis, earlier era tuberculosis. Those things are no longer seen. And a lot of amyloid deposition, various proteins can get amyloid fibril formation, and they are currently less than 5% of the whole thing. So this is a very important slide, like what is the common etiology and what is the average age and how often you find a cardiac involvement. So generally, just for comparison, I have put the AL amyloidosis because that's the most common amyloidosis you are likely to encounter. So they are all clonal plasma cell low level proliferation. So that's the primary etiology. Then, when it comes to the variant forms of ATTR amyloidosis and the wild type, the variant forms can be of two types. One is cardiogenic type, and the mixed are the neuropathic type. So, generally, the age group is all elderly age group, whereas the some specific subtypes can be found in younger age group. And then wild type is generally disease of the elderly. Then cardiac involvement is almost 100% in the wild type, whereas it occurs in around 70% in the AL type. And ATTR types, it's around 96 to 100%. So basically, ATTR has more cardiogenic involvement, even in neuropathic and mixed. It's more common in late onset disease than compared to early onset disease. So in a way, like cardiac involvement is very, very common in ATTR amyloidosis, whereas it happens in roughly around 70% in AL amyloidosis. And it may not be seen in only young onset neuropathic forms of ATTR amyloidosis. So what are the specific features? Can by clinical picture alone, can we say that this is ATTR, this is AL amyloidosis? And the patient has a pre-existing diagnosis of multiple myeloma or future suggestive of multiple myeloma, which is also not very common in AL amyloidosis. So it is not difficult to differentiate. Maybe the presence of a renal involvement, significant renal involvement, will possibly will be suggestive of, especially nephrotic range proteinuria, will be more in favor of AL amyloidosis. And periorbital ecchymosis is something that is more commonly found in AL amyloidosis. Whereas lumbar spinal stenosis is more common in both variant forms as well as the wild types of amyloidosis. And obviously, the neuropathic involvements, polyneuropathy, is more common in the neuropathic forms of ATTR amyloidosis. And carpal tunnel syndrome is commonly found across the board. So I think that may not be able to differentiate. So earlier, I'll look at the various stages. I will, for the want of time, I won't be going to the staging part of it. But look at the survival rates. For various survival rates, it's a very bad disease. It's almost equivalent to many cancers of today. The amyloidosis is a pretty bad disease. It almost you give a death sentence to the patient once you diagnose cardiac amyloidosis. So what about the epidemiology of how common is amyloidosis? As at the introduction, I told like it's often misdiagnosed. Look at these numbers that are quoted from the Western literature. Like all patients of severe AS undergoing TAVI, 16% of them are diagnosed to have amyloid deposits in the LV myocardium as well as in the valves. Well, and 60% above 60 years, above 60 years, patients who are hospitalized for HPEF, they have around 13% may have ATTR cardiac amyloidosis. So this is unbelievable. Like if you look at it, so I think we are missing it left and right. So that is the problem. So what about data from India? Data from India is extremely minuscule, and this is one large study from our center which looked at 40 patients of cardiac amyloidosis in the recent past. And the earlier era studies are, I think, are very limited. Even in this study, they didn't do the typing which is AL amyloidosis or which type of ATTR amyloidosis. That was not done. So this is one another interesting study that we did. One of our thesis that was done, which is published in JAC Oncology. We studied 46 patients of AS, where we found the amyloid thyroid transthyretin deposits were suggestive of in around 57% of patients had deposits in the myocardium as well as in the valve. So how do you diagnose when you are going to miss it? So because there is exact specific feature that are there, we always try to associate, like for example, a carpal tunnel syndrome or a polyneuropathy or a typical feature on ECG, echo, and MRI may not be found in most of them. So they all commonly present like your routine day in and day out heart failure patients with the clear symptoms of heart failure, and there can be conduction system disease. So anybody with heart failure, elderly with heart failure with conduction system disease, or a patient already on a pacemaker, or patient having atrial fibrillation out of proportion to LA enlargement, all of them having pseudo-infarct pattern, all those things you should have a very, very high index of suspicion. Any associated neurological symptoms or musculoskeletal symptoms and renal involvement, you should have a high index of suspicion for diagnosing cardiac amyloidosis. I think ECG plays a very important role. Let us keep it very simple. The patient clinically as well as on echo has evidence of LVH, whereas on ECG there is no LVH. It's as simple as that. There is a low voltage pattern in 50% of AL amyloidosis. In inferior and anterior pseudoinfarct pattern is seen in 70% of patients. So normal ECG is absolutely rare. Like for example, it's in only 5% of AL amyloidosis and 10% of variant forms of amyloidosis. And since wild type is a very elderly disease, almost everybody has abnormal ECG. So the typical feature is that the typical arrhythmia that is seen is AF. And ventricular arrhythmias are rarer than NSVTs. So in ATTR specifically, low voltage is seen in roughly around 40% of patients. LVH is seen in 15%. AV blocks and atrial flutter or AF is seen in around 40 to 90% of cases. So this is a very characteristic appearance that if this stage happens, then possibly none of us will miss it. There is a biatrial enlargement, there is thickening of the interatrial septum, there is biventricular hypertrophy. At the same time, ECG doesn't show, and there is characteristic cherry on top appearance that is found in the speckle tracking because the apices are not involved in the amyloid deposit in the earlier stages. So this is a very characteristic appearance that happens. So you find a biventricular thickening, dilated atria, dilated IVC, there is pericardial effusion, and there is characteristic apical sparring, and mass to voltage area increases diagnostic accuracy. So in other words, anybody who has severe restrictive pattern with some form of LVH will be the starting point of amyloidosis, and some vague non-normotensive patients or mild hypertensive patient disproportionately showing heart failure signs, then you should start thinking in terms of amyloidosis. And then the MRI, even though MRI is very, very helpful, we always think that MRI can be diagnostic in amyloidosis. I will show you some data. The MRI shows whatever we see in echo better in a cross-sectional way, where they can cut it in various sections, and it helps in identification the scar pattern and has some value in identifying the extracellular matrix component. But it is neither necessary nor sufficient to establish a diagnosis of amyloidosis. Its sensitivity and specificity is roughly around 85 to 90%. It has increased T1 native T1 volume because of ECF volume increase because of amyloid fibril deposition. It shows diffuse LGE. That means it's a diffuse LGE, not fitting into any particular vessel territory, as would be expected in a coronary artery ischemia. So it will be subendocardial favoring AL amyloidosis, whereas transmural ischemia will favor transmural LGE will favor ATTR amyloidosis. But definitely, MRI cannot be used to differentiate between AL and ATTR amyloidosis. Those who are interested can refer to this article that is published, which is a very, very interesting article looking at various other sequences that can be used to differentiate amyloidosis from other things. The most simple, how do you diagnose once you suspected? From your history, physical examination, ECG, echo. So you commonly do a light chain assay. The first step is to do a light chain assay. And if light chain assay is positive, then you go for, this is more likely to be AL amyloidosis, and you go for the affected organ surrogate site biopsy, which will include a fat pad aspiration or a rectal biopsy, or you can go for if there is a nerve involvement, nerve biopsy, or you can go for a EM biopsy. So that will solve our AL amyloidosis part. But if the light chain assays are negative, then you are supposed to do what is technetium-99 pyrophosphate scan. So generally, pyrophosphate scan is, I'll come to this in detail, is positive. Then you are supposed to do the genotyping for ATTR to differentiate between the wild type and the variant types. So I will not be going into the details of how do you do the light chain assays. I think most of your hematologists will help you in this. You can do serum and urine protein electrophoresis, but more importantly, immune fixation electrophoresis has become the standard of care now, along with the free and light chain assays can be done. But up to 23% of patients with ATTR wild type may have coexisting monoclonal gammopathies. That's something that we have to keep in mind. So the elevated troponin can be there and BNP levels can be there. They will be informing about the prognosis. But TTR levels can be nowadays measured in India also. They have some prognostic value in wild type and diagnosing ATTR importantly. So the most important non-invasive imaging to diagnose ATTR amyloidosis is POP scan. So POP scan, we compare it to the rib uptake, and based on that, it's graded from 0, 1, 2, 3. So anything above 0, grade 2 and 3 is relatively specific for ATTR amyloidosis. And then you compare it with the SPECT increases the sensitivity and specificity of it. So it can actually differentiate the ATTR amyloidosis from AL amyloidosis. And then the Perguni score, that is cardiac amyloidosis, cardiac uptake versus the rib uptake can be differentiated. Heart and contralateral lung uptake, if it is more than 1.5 after 1 hour, then this shows worse prognosis. If it is a grade 2 or grade 3, it is almost 100% specific for ATTR amyloidosis. There can be false positive, 10% of grade 2 can be AL amyloidosis, prior MI can be there, rib fractures, HCQ users, and very rare forms of amyloidosis can be false positive pictures can be found. So then, obviously, amyloidosis is a histopathological diagnosis. You need to show some form of amyloid protein that is deposited in extracellular matrix of the various tissues. The gold standard for a cardiac involvement will be endomyocardial biopsy. The surrogate biopsies is only positive in 45% of ATTR amyloidosis. Limbens are mostly they are very useful in AL amyloidosis. The various things that can be drained is the typical fluorescence that is seen and the various hematoxylin using strain. Apart from that, then you do the Congo red with polarized microscopy and then crystal violet. And then most importantly, you do the immunohistochemistry and mass spectroscopy is considered the gold standard to differentiate between various types of this. So this is the kind of nutshell what we should be doing to diagnose. So that is anybody comes in with suspected amyloidosis, we should do monoclonal protein evaluation, most likely with immune fixation electrophoresis and free chain levels to be measured. If they are positive, most likely it is AL amyloidosis, go for a biopsy. If it is negative, then you do a PYP scan. PYP scan is positive, think of ATTR amyloidosis. Then you go for the genetic testing because the TTTR silencers are only approved for variant forms of ATTR, not for the wild type. So then that is what the importance of doing the genetic testing. So in nutshell, this is how we approach the treatment. Like for example, if you have a confirmed cardiac amyloidosis, you have disease modifying therapy. AL amyloidosis, generally we go for various plasma cell therapies, which is not part of the talk here. Then I will be talking right now about in ATTR amyloidosis, wild type as well as the variant type. So you have cardiomyopathy, then tafamidis is indicated. Then if it is neuropathy, TTR silencers are indicated. And then you have the wild type tafamidis is indicated. Basically, TTR silencers are indicated in the neuropathy forms. So what is the basic therapy? Basic therapy is the TTR stabilizers and TTR silencers. These are the various therapies that are available. I'll be discussing in brief about all these things. Like so, tafamidis is a transthyretin. Actually, what about TTR? What is this TTR? It's a transthyretin synthesized in the liver. It is primarily used in the transport of retinol as well as thyroxine. So the fibrogenesis happens because of this, then the filaments are formed. This is tafamidis binds to thyroxine binding site of TPR and prevents the formation of this pleated structure. So the dose that is there is in two forms. One is the tafamidis 61 mg OD and tafamidis meglumine, which is 80 mg OD. They are both of them are biologically equal. The adverse effect major is diarrhea. As I told you, the cost becomes very prohibitive. It's roughly around the cost has come down slightly. It's around 2,000 rupees per capsule, but roughly around 9.5 lakhs is the estimated cost per year. So it's really very expensive. At times, even though we diagnose a lot of patients, only few patients are actually able to afford the therapy or are under our follow-up. So this is a major trial that happened. This is the ATTR ACT trial, which showed lower all-cause mortality with the 80 mg of tafamidis at 30 months follow-up and lower rate of CV hospitalization. These are the curves that started diverging somewhere around 15 months randomization. And it was reasonably effective across the various subgroup, especially for cardiovascular hospitalization, but not for survival analysis. So coming to TTR silencers, there are various agents that are there. The patisiran as well as the inotersen, they are all actually primarily the RNAs, the small interfering RNAs that target the hepatic synthesis of TTR. So they have been evaluated in the Apollo trial as well as the Apollo B trial, and they are currently not available. And then even if they are available, they are not going to be used in India because the cost is very prohibitive. It's around 3.6 to 5.4 crore per year per patient's life. So it's really very expensive. And then this is a relatively simpler agent, which is it's an NSAID that stabilizes TTR in vitro. It is associated with reduced progression of amyloid polyneuropathy, but it needs a larger trial to get it going. But generally, it's avoided in patients who have recent heart failure decompensation. So then you have various oligosense nucleotides, that is inotersen. These are all again, there are some evidence that these are useful, but primarily the cost becomes prohibitive. These are the various trials that are undergoing, and most of them are likely to have the results out in a few years' time. Various congeners of these TTT silencers, small interfering RNAs are undergoing various trials. So this is another interesting gene editing that has also is possible. So since they understood the protein structure, how the split formation happens, a lot of these experimental therapies are coming into vogue, and in few years' time, some of them will become reality. What about other therapies? So the orthotopic liver transplantation can be done with a 5-year survival rate of 100%. The pre-implant cardiomyopathy is generally considered a bad thing. Whereas without cardiomyopathy, it is a better thing. Doxycycline and green tea, they are not preferred in the era of tafamidis. Just I will finish with the cardiac manifestations and how do you treat that. So restrictive cardiomyopathy in heart failure is the commonest one. And there are various arrhythmias that can happen, atrial arrhythmias, ventricular arrhythmias, and AV blocks. So the primary therapy of heart failure remains the same, like any restrictive cardiomyopathy. The volume management is the mainstay. Narrow euvolemic window is there. They are actually very, very preload dependent. So loop diuretics have to be used very, very cautiously. Then beta blockers are poorly tolerated. AC inhibitors, ARNI, and digoxin is generally not recommended. SGLT2 inhibitors have insufficient data as of now. So these are the various arrhythmia. Atrial fibrillation you are supposed to treat with anticoagulation, irrespective of the CHATS2 score. And rhythm versus rate control, there is a big debate. We don't know the thing. And in patients who are not candidate for anticoagulation, you can think of LA appendage occlusion. So high degree AV block needs a pacemaker, and ICD is a separate discussion on its own. So the various heart transplantation can be considered with various algorithms that have been proposed. So to conclude, underdiagnosed requiring high index of suspicion. The distinction is AL and ATTR amyloidosis very essential for appropriate management. It requires actually an interdisciplinary coordination for evaluation and management. And therapy is emerging, and it's really holds a lot of promise to this deadly disease. Thank you for your kind attention.
Thank you, Ramakrishnan. Excellent talk. A very exhaustive discussion on a subject which is relatively new. And the interest has raised because of a few factors. Number one, earlier it was only the cardiac biopsy which used to say whether a person is having a cardiac amyloidosis of whatever form. But now, non-invasively, with nuclear scanning, it has become possible to make a diagnosis, particularly in grade 2 and grade 3, with 100% sensitivity and specificity. Secondly, earlier there was no medicines which could be given to these type of patients. Nowadays, at least we do have some drugs, some mechanisms by which you can arrest the progression. You may not reverse the process, but you can arrest the progression of the disease and thereby improve the longevity. So these are the factors why this has become a very interesting area of research and for the clinicians as well. Earlier, what we used to see, a patient is coming with a conduction defect, with a complete heart block or an advanced grade of heart block. Otherwise, the heart was normal structurally, at least to echo and other conventional measures. Many of these patients perhaps might be having amyloids, and this amyloids also involve the conduction system and can lead to this type of conduction abnormalities, which we come across quite a good number of conduction defects in this part of the country. Excellent talk. May I request Dr. Aniruddha?
Sir, actually, I have two questions. One thing is that how long this disease is modifying? This lifelong medicines, so long you have to give. So it's really a costly affair at the moment. Second thing is that in advanced stage of the disease, you cannot reverse back. Only you can control from that particular type. There is still no drugs is available we can reverse back. I think so. And third point is that, sir, you have said the low voltage ECG and is the most important thing, that is normal case. But in certain type of hereditary ATTR, you can even get a high voltage ECG in certain percentage of cases. So high voltage ECG is not even if you get some patient is not immune to diagnose ATTR amyloidosis. Am I correct? If I am correct,
Yeah,
please.
absolutely, sir. You're absolutely right. I think this is a lifelong therapy, number one, and it's a really, really costly affair. And there is some effort from our side to include it in the. There is a category of medications available for orphan diseases, like so. There are some government schemes that are available for orphan diseases. I think we are trying to include this therapy into that. So that happens, but they are all elderly patients. That is where the problem is coming. If it is a younger patient disease, then government would have approved it by now. So we are
Yeah.
again trying that. Number one. Number two, sir, I told you maybe I was rushing through that. So even 15% of patients with ATTR amyloidosis can show LVH on ECG.
Yeah.
So it's absolutely right that it's not the typical. So they can have low voltage complexes or typical pattern of low voltage here and normal voltage there. That is also possible. Or some of them can have LVH also. So ECG can kind of guide you or make you suspect amyloidosis. So that
So
is valid.
one more point, particularly that is the one. Sorry, I forward to let the if I can remember this one. I'll tell you later.
Ramakrishnan, may I?
Only my take-home message is that whenever you see LVH on echo and patient is dyspneic and has BNP level elevation, always suspect amyloidosis in an elderly patient. If there is normotensive, they are normotensive.
I remember the question. That is that nowadays we do not do so much of endomyocardial biopsy because the pyrophosphate cancers quite give the diagnostic features into the diagnostic of. We may not need the histological diagnosis to treat the patient. Is it correct?
Sir, you are right, but the endomyocardial biopsy may not be needed, but some tissue biopsy is generally confirmatory. Like with POP scan of 2 or 3, it's generally okay, but oftentimes you don't get that 2 or 3. That is our problem. Once you do a large number of volume of scans, so some of them may end up having grade 1 positivity. So that is kind of non-specific. You don't know what to do, and then you end up doing a biopsy. And generally, in terms of prognostication and the other thing, it's various subtyping. If it is possible, it is better to do. Like we do in an academic institution, we always do an endomyocardial biopsy.
Vijay?
Yeah, so I was asking that heart failure, preserved EF, and restrictive cardiomyopathy. This comes in the differential. What about heart failure, reduced EF? Do you get amyloid diagnosis? That's one question.
So
you answer then.
Obviously it goes into that phase of reduced ejection fraction over time, and often at that phase you can see like a very, very thick LV, but it is 30-40% contraction. Like so, then it is really obvious most of the time. In that case, generally it's quite obvious. It's very advanced and it's quite obvious.
Yeah, and in a non-heart failure patient like HCM like patients, do you ever get a diagnosis of amyloid?
Sir, generally, not generally. We have a differential of rasopathies in younger patients with HOCM, but generally, very classical hypertrophic obstructive cardiomyopathy, it is uncommon. With the caveat being that elderly at times can have an unusual form of acquired LVOT obstruction that can happen. That can be confusing with HOCM. When they become volume depleted with LVH, they can show because of the bump in the LV septum. So that can be a differential diagnosis. But generally, that confusion doesn't happen in the era of cardiac imaging.
Thank you.
One very important therapeutic issue is if somebody is having atrial fibrillation in a patient of ATTR CM, irrespective of the CHA2DS2-VASc score, the patient should receive anticoagulation.
Anticoagulation, absolutely.
Lifelong, that too.
Absolutely.
I think our time is over.
Yeah.
And
thank
we
you
will
very
move
much.
on to the last speaker, last session of the today-long conference.